here. I think you can see them. Tell me if not. And I just want to first say thank you so much for asking me to speak here today. It's such an honor to get to talk to the Florida PQC. We all watch each other's work, and I'm always impressed with what you as providers and leaders are doing on the ground, as well as your leadership as well. So thank you so much for asking me to come present. So I'm actually very grateful to get to talk about this as well, because I can see this at two levels. One, I help co-direct our perinatal quality collaborative in general, which includes neonatal as well as maternal side. I'm also partly in charge of the maternal side of our perinatal quality collaborative. And I do a lot of this work on the ground at the Boston Medical Center where I work. And I've been very lucky to work there for a while. And we have an excellent referral center for patients, women who are pregnant with substance use disorder. So I've really been able to look at this from all different levels and angles. And so I really feel for you guys how hard it is to get this work going. And I'm glad to get a chance to be encouraging and talk to you. So I have no disclosures. And what I wanted to do today was just, and I kind of think that a lot of this will be sort of reflective of what I've just seen with Dr. Seppenfield and Estefania's work or presentations there. And, I think it'll add to that, I think, hopefully synchronize and really help you feel like, you can do this and we can do this to help our patients. And there's a lot of hope here. So first, I'm going to talk a little bit about the why. Like, why are we doing this work? Why do we do this work? Why do I do it? How can we help all of our teammates around us do this? We're going to talk about some of the tools. The good news is tools keep amassing, and we'll go through some of those. And I'll tell you what we're doing in Massachusetts. Hopefully some of that'll you can use it, of course, or you've got similar stuff and it might just tweak something in your head to use it in Florida. We'll talk about the data loop and how to use data. So you guys have some really impressive data already being generated. And then finally, just a little bit about organizing the work, excuse me. So the why, I've been doing quality work for about 8 or 9 years now. And, I'm an IHI acolyte, and I love quality improvement. And we had done bundles for hemorrhage and for hypertension in our department back in 2015 and 2016. And I really felt like we were doing a great job. And one day I was downstairs and we were having a memorial actually for women who we had taken care of in our service. And we take care of about 200, 250 women per year who we know have substance use disorders. We do a wonderful job in the hospital and during their care, and we take care of them. And it was really shocking and upsetting to see 9 faces presented. So to us and these were women we had cared for and had delivered babies with us. And we were remembering them with their families and thinking about just how we really need to do a better job. So that's when I really started to think we need to do this work. Dr. Sappenfield pointed out very well, and this is actually, we're redoing this data. This is from 2014. 41.4% of our patients, and it's way higher now, have pregnancy-associated mortality. So not pregnancy-related, pregnancy-associated. And this is Massachusetts data. And so we've been knowing this for a while, and this is part of the motivation to do the work. And the thing is, this has been hiding in plain sight for a while. If you look back here, this is a study from Illinois up through 2011. Where they already were seeing substance use and overdose as a leading reason for deaths in pregnant and postpartum women. When we talked to our colleagues about this, who are primarily midwives, obstetric care providers, and and they say, I didn't really know this was happening. You showed this as well. This is really a problem after that 6-week postpartum visit. And so you can see here, substance use related deaths really occur for women in the 42 to 365 day mark. And so our family medicine and other colleagues around the university and the hospital system are seeing this, but we weren't really recognizing it because it happens really after our interactions with patients. And like Dr. Stephanie was noting, and it really is an amazing opportunity to have somebody with us for so many visits and so much time with so much motivation to find some level of control of their substance use disorder, that we really do have an amazing opportunity as pregnancy care providers to help somebody out. And those patient testimonials really brought that home. We also think about this in terms of disparities or inequities. And when we started to look at our SMM information, severe maternal morbidity, and we looked at patients who are white versus non-white in 2016 to 2018. And this is for women who had the diagnosis of opiate use disorder, also on their hospital discharge information. We see a wide disparity or inequity in severe maternal morbidity, with non-white women having twice the rate of severe maternal morbidity than white women. And that's not actually surprising. We just published on this because when you look at Black and Hispanic women, on the top here, this graph, you can see that they have a much lower chance of receiving any medications for opiate use disorder. So we really need to work hard in that space within the opiate use disorder and substance use disorder work that we do. Now I'll talk just a little bit more about that. So what do we do? What have we been doing? What can you do? Get involved. Do exactly what you're doing. Show up. Start getting information, learning what your resources are, getting the story together to bring to your teams, both inpatient and outpatient, to do the work. We've had 5 large summits now over the last few years, every 6 months, where we bring together people from around the state. We've had over 400 people at our last summit, with people actually waiting to get in. And our next summit is on the 17th and 18th of November. If anyone's interested, we could talk about having you come. That'd be great. And at these summits, we really do a lot of presentations, both for neonatal work that's going on, maternal work. Agencies from around the state come in and talk. We really have had excellent participation. The way our PQC works is that we don't have quite the firepower to build a lot of content, although we do some, but we really have been fortunate to become one of the hubs where people come together around this topic to understand what's going on in other spaces and think about how they can help each other and borrow work. We also have webinars. We have 42 hospitals who are delivering hospitals now for obstetrics, and our first wave of these webinars occurred about a year and a half ago, got a little delayed with COVID, and we finished their set of webinars, 12 webinars. And we have a monthly agenda. We always get together, we say hi, we collaborate, tell people, say what's working, what's not working, try to help each other. We always do some teaching on QI. We have a set of teaching slides that we'll use, and we present those. And then we always have a guest topic, and I'll show you what those are. And it's been really very well received. And again, I think it's helped, again, just serve as a hub and a place for people to be able to come together and hear what's going on in other spaces, both at other hospitals and what resources are available around the state. So here are QI topics. I won't run through them. We always try to build QI understanding and process into the work we do. We feel like the ideas of bringing people together, setting up measures, following those measures, and doing implemented PDSA implementation is really important. We also have a set of topics that people really were interested in from around the state. How to do plan of safe care, what's going on with the checklist that we can talk about if you ever want to, from Dartmouth, Daisy Goodman's work and the NEPQIN's group, linkages to care, et cetera. You can see the list here, but we've had a lot of people calling in, I think, just to sort of see what's going on in those spaces and what those resources are. So a little bit more on what are those resources. In the state, I have to say we've been really lucky that with time and with funding, we've had a lot of things develop and become more available over the last few years. And these are some of them. I think you might have similar activities going on in Florida, and feel free to chat them to each other. If you see something, that'd be great. Or we could talk about them right after. And here's some of those that we have in Massachusetts that we've been part of. So the MASPERT is the Massachusetts SPERT training program, and they were focused a lot on substances and alcohol use in all populations, but we were able to work with them to bring them into our meetings to help explain to them what our QI process is, what's the AIM bundle, and have them really help promote that as we have helped get them into multiple spaces around the state to help teams get ready to do SPERT in innovation in their space, because you can't really do screening unless you have a plan on how you're going to meet the patient where she is and help her get to the next space. One of the things that came out very early was that we needed more information about trauma-informed care. Over 90% of women who have substance use disorder or opioid use disorder will have a history of trauma. So understanding how to approach all of our patients, including our patients with this condition, is really important. And we were lucky to run into a Robert Wood Johnson funded group at the Brigham and Women's Hospital called the Care Clinic. And we actually contracted with them to do webinars, and we were going to do in person, but it's become webinars with COVID, and really helpful trainings from around for the hospitals around the state. We now actually have this videoed, and we're going to be posting it on our site so that people can get actually CEUs and credits for it as they review it with their teams if they weren't able to do a live webinar. Provider training for medically assisted treatment, or MOUD training, has been something that we've focused on for the last few years. The OBOT, which is Office-Based Addiction Treatment Team, and SAMHSA have been providing more trainings around the state. We've done 4 together, where we basically were able to get obstetric providers to those trainings, and they do continue around the state, and we help give information on that to people, and also other options for MAT training. So this is the Institute for Healthcare Recovery. It's a wonderful group. And what they've done that's been really helpful for us is a lot of work with the state on the plan of safe care. They have really nice product here. If you're interested, the family support plan template. They have a 1-page, they have a longer version. We're helping our institutions really start thinking about this during the pregnancy. And in fact, a lot of us are now doing at the first prenatal visit, starting to fill out the plan of safe care. It is a mandated activity for patients with opiate use disorder prior to discharge from their delivery admission. And having that work done prior is so important. And it's really, it's been well received, the work with the patients. I'm really happy that this has been able to be put through. I'm going to talk a little bit more about linkage, but they also, if you go onto this website, have a really cool resource where you can go on, you put in your zip code, and they actually tell you what services are available nearby. So if you were a provider and you wanted to help find a food pantry or another service that patients would need, you can do that through this website if you live in Massachusetts. In terms of linkages to care, we have what's called MCPAP for Moms. So it started out as actually a child psychiatry access program. And then they started doing mental health linkage for moms and pregnant women. And then actually recently they got funded to help with substance use disorder as well. So they have an online person all days to help with immediate answers to questions, as well as setting up care and providing linkage to providers, both for mental health care as well as for substance use disorder. So they've been really valuable, again, as part of that process. So when we meet patients who have a need, we're able to immediately help them address it. We're lucky we have what's called the Moms Do Care program, which is funded by DPH and helped managed with IHR actually. And this is a real large peer mentoring group, and they help at different hospitals, not all the hospitals at this point, but we'd love more, but really excellent training for mothers in recovery, as well as providers, so that we're able to provide peer mentoring and more complete, excellent care for patients with substance use disorder. And finally, Healthy Start has been a real partner in all of this. And I know that they're very involved in a lot of the work that's going on in Florida. This is a little bit old slide. I know that the 25th anniversary passed a little bit ago, but really hats off to Healthy Start and all the work they're doing in this space. You get help from people you might not always expect, but we really got lucky when we were thinking about substance use disorder, and we were talking to leaders at the Boston University School of Public Health. And what we did is we asked, they wanted to have some students do some deeper dives into certain medical problems. And we said, why don't you come look at it at our large program actually at Boston Medical Center. I think about how stigma and bias affect our care. That was one group. And then also another group looking at how implicit bias and racism is evident in our care. And so we had these two wonderful groups of students come and understand a little bit better through a variety of modes how we do our work and what we needed to improve. And we actually have taken that learning to the collaborative. And they've presented in our webinars, they presented at summits, they presented to our leadership. And really those have been an excellent experience for our team at our hospital, for our collaborative as well. And I'm hoping for those students as well. So we learn to take help wherever we can get it. And I think that we've helped those students as well. Also, to improve our work on equity, we are working with the Institute for Perinatal Quality Improvement, which is led by Dr. Deborah Bingham. And she actually has been doing trainings already with a lot of nurses in our state on Speak Up for Black Women. This is a really powerful education and plan for quality improvement style improvement in your space around care of women of color. Okay. We also have been lucky to have collaboration with specialized treatment sites. When we started about 2015, really thinking about this, there really was one big site, and that was actually at the Boston Medical Center. We took care of a lot of the patients who were identified or self-identified with substance use disorder. But since then, a lot of new programs are starting up. So there's one at the Brigham called it's called the Bridge Clinic. Mass General has the Hope Clinic. This is us, the Respect Clinic. And then a really nice amount of work has been done on the Journey Project, which is an online tool to help patients understand and providers understand really the journey for patients with substance use disorder and ways to think about it and prepare. So we've been really lucky as we've helped these teams grow, and we've also gotten a lot back from them as they've reported back into our collaborative what they're learning and on their work. And finally, there are tons of resources out there. The Northern New England Perinatal Quality Improvement Network. I mentioned Daisy Goodman. She's and her team there have done an amazing amount of work with a lot of excellent attention on the checklist. I had seen that there was not as much testing for infectious disease, Hep C in particular, and this checklist is really meant to be for providers and for clinic sites to be able to know what we should be doing for patients who are being treated for substance use disorder, whether or not you're their primary treater or not. ILPQC, as usual, amazing work that they're doing. They provide a lot of content, and I think I saw a couple things on Dr. Sappenfield's presentation that comes from ILPQC. We've been working with them for a long time around this topic and others. CMQCC is doing a lot of work on substance use disorder, and AIM, of course, we've got to look to AIM and the bundle. And I noticed that your measures are actually pretty tied to the AIM bundles. So there are lots of resources, and the trick is to get out there, get on the web, and start using them. Okay, so a little bit about data. And this is where we are. I thought you might just want to see where we are, what we look at. We have more data points, and this is through a REDCap database that we keep primarily collected through our neonatal colleagues. So thank you to them. And this is our medication assisted therapy for mothers of opiate exposed newborns. And so we were lucky that a lot of patients were initially treated at one place. So they had a pretty decent rate. And as the care has been moving, becoming more localized around the state, we've been happy to see that we have a large percentage of our patients in treatment when they deliver. And this is for exclusive medication, or MAT, for the opiate-exposed newborns mothers, around 60%. A little bit about the babies. We're looking at pharmacologic care, and you can see that we've been able to decrease our rate from 52.6 down to 36.9% of babies receiving pharmacologic care. We've been working really hard on the Eat, Sleep, Console process with our neonatal teams and pediatric teams, and I think that that's taken effect. We also look at length of stay, and we've had some decrease in that, which is excellent. We actually had a quantifiable difference, which is wonderful. And you can see it's still sort of eking down a little bit more. Also important that we look at discharge to home with biologic parent. We don't actually have a goal to know what's the best rate for this, and we generally stay around 75%. So I'm almost done. When we think about this, and it's like with every bundle, there's a lot of stuff. And if you were to look at the AIM bundle, and when I looked at the slides and you're like, oh my goodness, there's so much stuff we're measuring and thinking about, it's important to think about this in a sort of broken down fashion. And I've been, when I talk to hospitals or myself about this, really think about it like making a meal. Don't call out the meal when you know what it is. But and my kids would shudder to see me doing this. But when you think about making a meal, you don't do everything all at the same time. You do some stuff early, maybe your appetizers. You do different work at different times because it's going to take a different amount of time. You have to do some things first. You have to put some stuff on the back burner. It's going to take a while. Some stuff actually, you're setting the table and you're really getting everything ready for people to do it. Have the policies ready. Have the work ready at the hospital so that people can be cared for. Different parts come together at different times, but they all have timelines and they all come together to make one ultimately meal, in this case tacos. And it's really about organizing all that work in your space so that it comes together fairly organically and fits together right, so that you actually end up in the right space and everybody can move forward together. I have another tool that I like to use. I've started using these actually a number of years ago. I basically, and I'm happy to share this with anybody, but project management in and of itself is its own science and difficult thing to do. I'm happy to share. We have a progress tracker that we built for our hospital. We've shared it. It's up on our website for PNQIN. And basically, we just took the important things that were identified within the AIM bundle, said, let's put them up there. Let's talk about it, and then start doing some action follow-up, who's responsible, and the status. What I found is that probably if you start doing this in your site, your status is going to be done on a fair number of these things or in process. But it really helps the team have an idea of what else is going on around them for the work that you're doing, in this case around substance use disorder, and helps the team all stay on the same page as they build this bundle. You know, and ultimately, we need to just keep working on this. I've been thinking about it for a while, like the way we treat diabetes. You know, diabetes is a chronic disease. It does better, does worse. Some patients are able to take their medicines all the time, some not, but we don't stop taking care of them. We aren't afraid to screen for them, because we know if we screen for them, we can identify the problem, we can find them help. And for diabetes, as nutritionists and the medications they need, we know about how to take care of them in the pregnancy. We know how to take care of them afterwards. It's not scary. And that's really the goal for what we're doing here in setting up these systems. It should feel safe and feel whole for the patient and the provider. So that's really the goal that we're really working on here in the state, and at each individual hospital is really helping, whether or not you're a big center with all the resources there or a smaller space, and you really want to just be able to do a smaller part of this work, but know the rest is going on outside of your walls. Whatever it is, it is doable, and it's knowable, and there's a lot of good resource. There are a lot of good resources out there for you. So, I really encourage you to take that step. I'm going to come off of sharing and put my video up, and I encourage you to take those steps if you haven't, or take the next step if you're already on the way. Thank you very much.
Thank you, Ron. We can take one or two questions. Nicole, are there any questions in the chat?